Assalamu alaikum wa rahmatullahi wa barakatuh to all of you. Very happy to be here in Bahrain, and thank you, Ian, for asking me to come and present. It's going to be a quick review about hypercalcemia, and before that, now we're witnessing the second year for Badr, and the father of Badr, is, as you know, is Dr. Wayam Hussein. So I hope that I will live enough to see Badr be 15 and 20 inter-college, inter-medical school, and go to Ohio and take the fellowship in endocrinology and come back like the father, exactly like the father. So we hope to see Badr at that stage. Age plays a role. So 10 years difference for Wayam Hussein between 2009 and 2019, and mashallah, he's still very active and productive. And he's not only the father of Badr, he's the father of the ACE Gulf chapter. And now he's, this picture, this is in the 6th annual clinical congress of the ACE Gulf chapter, receiving the Ibn Sina Distinguished Service Award. Well deserved, Wayam. Speaking about the Gulf chapter, being the president, I'll take a few minutes to market our future activities. So this year activity, the annual congress is going to be in Riyadh. Please come and join us, 5th to 7th of November. This is the 8th annual congress of the American Association of Clinical Endocrinologists, Gulf chapter. In Bahrain, we're going to have an activity. So please, if you cannot come to Riyadh, this is earlier on. This is going to be on the 11th of April. A distinguished speaker in lipid and clinical lipidology. Nasreen Sayyid is taking the care of the organization of this activity. And we have this activity in Dubai next month, 20 and 21st of March, bone densitometry pre-certification course. So you come and take the course, and then you can sit an exam and get certified with the International Society for Clinical Densitometry and the International Osteoporosis Foundation certificate to read densitometry reports. I don't have any disclosures for this presentation. This is the outline of my presentation. A few words about calcium hemostasis. This is going to be a quick review, especially for those who are working in internal medicine and family medicine. Clinical presentation, the causes, how to approach hypercalcemia, the treatment options, and tips on primary hyperbara if I have time for that. So I put a lot of slides. So I'm not going to present all of them. So as time allows, I'll stop when I finish my time. So hypercalcemia is defined as serum calcium concentration, 2 standard deviations above the mean values. So the normal serum calcium range between 8.8 to 10 milligram per deciliter, which is in millimoles, 2.2 to 2.5 millimoles. It's the most abundant cation found in the human body. It's responsible for lots of activities in the human body, like neural transmission, enzyme activity, myocardial function, coagulation. 99% is present in bone, 1% in the extracellular fluid, and the extracellular fluid, 50% in its free ionized form, 40% complex with albumin, and 10% complex with anions such as phosphate. A lot of formulas are available to correct for albumin levels, and a lot of debate whether these formulas are accurate. So these are 3 of them. There is no study to compare each to another. So use whatever you think is correct for you. And many people say that most of the time you don't need to correct if the serum albumin is normal. And you can use the regular calcium. You don't need adjusted calcium, except when the albumin levels are abnormal. There are 4 organs mostly involved in calcium hemostasis. So parathyroid glands, the bones, the intestine, and the kidneys. And quickly saying, PTH, the effect on the bone, is to increase calcium resorption and stimulated by low calcium and high phosphate. So mainly PTH is a calcium resorbing hormone. It makes 125 in the kidney, and that increased calcium and phosphate absorption from the gut. And the effect of parathyroid hormone on the kidney, as you know, to activate the conversion of 25 to the active form, 125, and that will lead to increased calcium resorption, increased phosphate excretion, and inhibited by 125 vitamin D. Spectrum of hypercalcemia: mild, moderate, and severe. So we say it's mild hypercalcemia. If you look at the level using the ionized calcium, if you use the ionized calcium, on the lower part is between brackets is the ionized calcium. So 1.4 to 2. This is not working properly. So 8 to 10 is considered as normal calcemia, which is 2.5 millimoles. This is in milligrams. If you exceed coming between 10 and 12, this is mild hypercalcemia. Moderate between 12 and 14 milligram, which is 3 to 3.5. And if you exceed 3.5 millimoles, this is severe hypercalcemia. What are the causes? As you know, any dysregulation in the parathyroid gland, we divide them into PTH dependent and PTH independent. So the PTH dependent, as you know, primary hyperparathyroidism, which could be sporadic, familial, or associated with multiple endocrine neoplasia, type 1 or 2. And we know there is tertiary hyperpara, which is related to kidney disorders. Hypercalcemia related to vitamin D intoxication, and usually 25 vitamin D, D2 over-the-counter supplements. And that's very rare. As you know, there have been reports of patients using very high doses of calcium over-the-counter, and the toxicity needs a vitamin D level above 250 nanomoles. So accidentally, some patients utilize 10,000 international units of vitamin D for weeks, and no toxicity has resulted because mainly the body will regulate the formation of 125 from 25, the conversion of 25 to 125, despite the high doses of intake. Vitamin D related also is the cause of hypercalcemia in patients with Hodgkin's lymphoma and granulous diseases like tuberculosis and perilosis and so on, sarcoidosis. The other causes are medications, and mainly the medications are very rare to see nowadays: thiazide diuretics, lithium, used for manic depressive illnesses, milk alkali syndrome, which is ingestion of a lot of calcium supplements present in antacids, vitamin D intoxication, which personally speaking, I have never seen a case of vitamin D intoxication. Hypercalcemia can be associated with other diseases like hyperthyroidism, adrenal insufficiency, acromegaly, and pheochromocytoma, and usually it's a mild degree of hypercalcemia. We never see severe hypercalcemia in any of these endocrine disorders. If the PTH is mildly elevated, you think about familial hypocalciuric hypercalcemia, which is related to the abnormalities of the calcium sensing receptors in the kidneys. Now, if PTH is normal or suppressed in the presence of hypercalcemia, as you know, then you look for malignancy associated hypercalcemia, which is humoral hypercalcemia of malignancy. And this is, there are a lot of 3 or 4 mechanisms in which malignancy can induce hypercalcemia, which is either by PTH-RB, the PTH-related peptide, which acts on the same receptor as the PTH hormone, the regular PTH. Solid tumor can metastasize to the bone and cause local osteolysis in the bone, or through the secretion of cytokines, for example, multiple myeloma and breast cancer. So this is again the causes of hypercalcemia. So if you come to the main cause, the commonest cause, 90% of the cases of hypercalcemia are related to parathyroid hormone and malignancy induced. The PTH is usually seen in the primary care setting or internal medicine setting in the clinic. Usually it's mild to moderate, while inpatient with malignancy, these are the people who come with severe hypercalcemia. But some patients with prolonged hyperparathyroidism, so they have hyperparathyroidism for years, and then they can present to the ER with a calcium of above 3.5 and severe hypercalcemia. Familial hypocalciuric hypercalcemia, as we mentioned, again, it comes with elevation in parathyroid hormone, mild elevation, and we can distinguish between PTH hyperparathyroidism or familial hypocalciuric by measuring the serum, the urine calcium level. Bone causes immobilization, malignant invasion, as we mentioned, hyperthyroidism or other endocrine disorders, granulomatous diseases related to vitamin D overproduction in these granulomas. These are the causes, the main causes that come up with hypercalcemia, another representation of these causes here. And as we mentioned, the first thing that you do after taking a history and physical examination is to look at the parathyroid hormone and divide your patient. Is it PTH dependent or PTH independent? If it's PTH dependent, high PTH, measure the urine calcium, the next step. So the first thing is to measure the PTH. If it's normal or high, go for the urine calcium. If it's low, this is familial hypocalciuric hypercalcemia. If the urine calcium normal or high, this is primary or tertiary hyperbara. Tertiary hyperbara, the GFR will be low and the patient has very long chronic renal disorder. And then you see if this patient with primary hyperbara needs surgery or not. You go through localization and you proceed with surgery when you find an adenoma or other techniques of localization if the initial evaluation looking for an adenoma is negative. Now, if the PTH is suppressed, as we mentioned, you go for symptom-guided malignancy workup, do PTH-RB, and look for hidden cancers. Hematological malignancies, you can differentiate with looking at 125. So increased calcitriol that happens with lymphoma and granulomas. If malignancy workup is negative, test for other endocrine disorders, hyperthyroidism, adrenal insufficiency, acromegaly, and these are evident by history and physical examination. The management usually try to treat the underlying cause, discontinue medications that make the hypercalcemia worse, mobilize the patient as soon as possible, and the mainstay of therapy, as you know, is IV fluid. We'll talk about loop diuretics. Calcitonin sometimes used to gain some time in patients with severe symptomatic hypercalcemia, and we'll take your opinion about this in a minute. I personally find calcitonin not very effective, and as you know, the duration of action is very short, and patients develop tachyphylaxis for it. Intravenous bisphosphonate is, again, one of the elements of treating hypercalcemia, and corticosteroid for lymphomas and hematological malignancies. Dialysis can be used in severe cases. Now let's take them one by one. IV hydration. So in hypercalcemia leads to a decrease in GFR through a combination of the natriuretic effect of high serum calcium. So these patients, they present with dehydration, sometimes severe, and that makes the hypercalcemia worse. And it causes renal vasoconstriction, and impaired urinary concentrating ability. So it leads to a state of nephrogenic diabetes insipidus because of the activation of the calcium sensing receptor in the thick ascending limb of the lobe of Henle. Activation of the calcium sensing receptors leads to a decreased resorption of sodium and chloride in the lobe of Henle, and that will lead to more hypercalcemia. So if the activation of the calcium sensing receptor in the collecting duct blunt the response of this segment to the action of arginine vasopressin, and as I mentioned, this is a state which is similar to nephrogenic diabetes insipidus. Patients presenting with hypercalcemia are profoundly volume depleted, and that's why the first step is to give them plenty of IV fluid. So the first step, as I mentioned, aggressive IV hydration, calcitonin plus minus, IV bisphosphonates, and in refractory cases, we go for gallium nitrate or denosumab. If the patient has leukemia, lymphoma, consider corticosteroid. If the patient has renal failure, occasionally you come with a patient with severe hypercalcemia and the GFR is low and you're hesitant to give plenty of IV fluid. These patients, you might need to call the nephrologist and ask him to do dialysis against a low calcium bath. The loop diuretic. Now it's very traditional that all of us give lots of IV fluid and then push Lasix. And this practice, which I'm going to talk about in a minute after finishing the amount of fluid that you need to go, so we use 0.9% saline at 200 to 250 ml per hour. You might give initially 1 to 2 liter bolus, and some of these patients, when they are very sick, you might do invasive monitoring for them. So a central line to guide your fluid therapy if they are profoundly sick and need ICU admission. And the goal is to get a good urine output, 75 mils per hour. So push fluids till you get this amount of minimum of this amount. Some people say 150 mils per hour. You watch for volume overload and watch for electrolyte imbalances. So these patients, once you start high dose IV fluid, they might develop hypernatremia because of hypercalcemia-induced nephrogenic diabetes insipidus, and may require changing from the isotonic to fluid to hypotonic, so low quarter saline or half saline. Or some of these patients, if they are profoundly hypernatremic, you might shift to 5% glucose, dextrose. Now, the loop diuretic. This is a very nice narrative review of Lasix for hypercalcemia. And the authors concluded that, as you can see from the title of this paper, an unproven yet common practice. So Susan Legrand and colleagues looked at the effect of loop diuretics. So loop diuretics act by inhibiting the sodium-potassium chloride transporter in the thick ascending limb of the loop of Henle. So a loop diuretic decreases the lumen-positive charge that normally drives calcium reabsorption. So once you decrease the lumen-positive charges, that will lead to more calcium excretion in the urine. And in this paper, the review that was done by Legrand, they could find only 9 articles that documented the use of Lasix in the treatment of hypercalcemia. The last of them was published in 1983. And when she looked at the total number from these studies, they came up only with 37 patients. And these are the patients. As you can see, 8, 11, 1, 1, 1, 3 patients, 5 patients, and this is 6 patients. Majority of these trials, they used extensive monitoring. So they put the patient in the intensive care units, and without going into the details, the doses are so variable, and we'll talk about this in a minute, and the outcome was not very impressive. So the average dosage of Lasix was 1,120 milligrams. So very huge doses, not the doses that we use in our patients in the emergency room when we see a patient with hypercalcemia. And this dose of 1.1 gram was given over 24 hours, and the serum calcium using these huge doses of Lasix normalized in 14 of the 39 episodes in 37 patients with hypercalcemia. It was rapid over 12 hours only in 2 cases using these huge doses of Lasix. The lower dosages of furosemide were ineffective. So the kind of doses that we give to our patients, the 40, 60 milligram, were not effective in decreasing the serum calcium. The most important thing, monitoring was intensive with aggressive replacement of hourly urine output losses. And the conclusion of the reviewer that routine use of loop diuretics in the therapy of hypercalcemia cannot be recommended. So we use them only after your aggressive replacement of fluid and you are feeling fluid overload, or the patient has underlying heart failure or disease. Monitor that patient very carefully, and you might add Lasix in those who are fluid overloaded. The mainstay of hypercalcemia, I'm not going to talk about calcitonin because, honestly speaking, myself, I do not use it. The effect is very mild, in the order of 0.5 millimoles. Some people say if the patient has mental abnormalities with severe hypercalcemia, then to buy some time for the effect of bisphosphonates to act, which takes a couple of days, then use calcitonin. And most of the authors do not think that it works very well in these patients. Bisphosphonate, we have 3 agents that are used for hypercalcemia: pamidronate, zoledronate, and epandronate. And you need to adjust the dose according to the eGFR. You cannot use them if the GFR is below 30. In the extracellular space, bisphosphonates bind to calcium phosphate and stabilize the bone matrix. We know that their major action of bisphosphonates is to inhibit osteoclast activity through the inhibition of mevalonate pathway. So they enter the osteoclast, act on the mevalonate pathway, and at the end induce osteoclast apoptosis. They impair the cellular adenosine triphosphate dependent metabolic pathways and disrupt the osteoclast cytoskeleton and use apoptosis, and that's why they lower the serum calcium. What are some of the evidence for them? Randomized clinical trials with bamidronate, zoledronate, and ibandronate have all shown efficacy in the treatment of severe hypercalcemia, especially those with underlying malignancy. One of the studies demonstrated a dose response effect using bamidronate. So if you use the 30 milligram dose of bamidronate, you get 41% reduction. The 60 milligram resulted in 61% reduction in serum calcium. And the higher the dose, the more effective is bamidronate. So a practical approach is to give a dose between 60 and 90, not to use the 30 milligram, because only 40% will have reduction in their serum calcium. And this is given over 2 to 6 hours, and you might repeat the dose in 2 to 3 weeks' times if needed. The effect of bisphosphonates is influenced by the mechanism of hypercalcemia. They are more effective in cases of hypercalcemia associated with bone metastasis. And as you know, oncologists in particular, they are very aggressive in using them, not for hypercalcemia in particular, but to prevent bone metastasis. And they say that we have strong evidence that giving them every 1 to 2 months is effective in decreasing metastasis and prolonging patient survival. Higher doses the higher the level of calcium, the higher the needed dose for bisphosphonate. And in patients with humoral hypercalcemia of malignancy, the higher the PTH-RB, then the less the response to IV bisphosphonates. There's been some studies comparing, like this one, comparing zoledronic acid in a dose of 4 to 8 milligram versus 90 milligram of bamidronate, and they looked at the normalization of serum calcium by day 10 after treatment. Both doses were superior to midronate of zoledronic acid, were superior to bamidronate, with serum calcium normalizing by day 10. The 4 milligram dose resulted in normalization of calcium in 88% of patients. And this normalization lasted for 32 days. The 8 milligram, 87% normalized the calcium, and this lasted for 43 days. While 90 milligram of bamidronate, only 70% normalized in 18 days. So it's a common sense and a common practice nowadays that in many hospitals, they use zoledronic acid more in favor than bamidronate, mainly because the effect is stronger and more duration of normal calcemia. The effect is influenced by mechanism of hypercalcemia. So this is the previous slide, sorry. The other agent that has been looked at is denosumab. So patients who are refractory to bisphosphonate, especially in malignancy-associated hypercalcemia, you might try denosumab. And we know that it's an anti-cytokine that is very effective in patients to treat osteoporosis. Steroid inhibits the activity mainly of 1-alpha hydroxylase, so decrease the absorption of calcium from the gut. And the efficacy is based on case reports. And thus the dosing guidelines are uncertain. So in patients with tuberculosis, sarcoidosis, lymphomas, leukemia, you might use IV hydrocortisone, 200 to 300 milligrams for 3 to 5 days. And patients who do respond with normalization of calcium can be transitioned to oral prednisolone, 10 to 30 milligrams per day. So this is the pharmacological option in a table representation. And again, the major stay is normal saline. This is an old paper from the American College of Family Practitioners, where they mentioned low-dose Lasix, but this is no longer recommended. Bisphosphonate, calcitonin, and steroid. Some patients who are very refractory, so you use all the options that you have, IV hydration, and then you go to bisphosphonate, and still the serum calcium is elevated. There have been reports of using mithramycin or blycamycin 25 microgram per kg per day IV over 6 hours, or gallium nitrate. And these are very strong agents with lots of side effects. So blycamycin has marrow, hepatic renal toxicity, and gallium nitrate also has renal and marrow toxicity. So rarely we revert to these, and most of the time we can treat our patients with what we have in our hands. So this is a summary of the management of hypercalcemia. Now, a few words about primary hyperparathyroidism, and we know that we came across three generations of primary hyperpara in the 1970s, very severe disease with lots of bone abnormalities. So this is the most common cause of hypercalcemia in the outpatient setting. And in the 2000s, now we are seeing more subtle biochemical signature, namely only with PTH level elevated at first and normal calcium. So in the 1970s, this is the picture that people used to see with very severe advanced bone disease. And we know the biochemical signatures of primary hyperpara, where you get mild elevation of calcium, 10.7 in general, around that level. Phosphorus is on the lower range of normal, mild elevation of alkaline phosphatase. The PTH is significantly elevated, 25 vitamin D, 21 nanogram, which is low in majority of patients, 125 in the upper range of normal, and urinary calcium is elevated. So this is the typical picture of primary hyperparathyroidism. We know about this meeting, which is done in Florence. This is the 4th International Work Group in the management of asymptomatic primary hyperparathyroidism, which delineated how the presentation, the evaluation, the surgical and the medical management. And if we come to the presentation, I think most of us know about this severe disease in the 1970s, and now we are facing what's called as normocalcemic hyperparathyroidism, patients with high PTH and normal serum calcium. You must rule out vitamin D deficiency, 25 vitamin D less than 30 nanogram, renal insufficiency, medication and hypercalciuria, GI malabsorption, and other metabolic diseases that could be associated with elevated PTH. So rule out mainly vitamin D deficiency in this part of the world before saying that this is normocalcemic hyperparathyroidism. This is the Columbia experience. We know John Pelizikian, most of our senior colleagues in the room know John, and Shoni Silverberg. They published a lot on hyperparathyroidism. So this is one of the earlier reports of patients with normocalcemic hyperpara, 37 patients, the age is 58, mainly women, 95%, men 5% only, and mainly post-menopausal females. So this is the commonest kind of patients that they've seen. Majority, they present with low bone mass. Kidney stones in 6%, fractures 11%, and other presentation in 10%. This is the biochemical characteristic of these patients. Mainly, calcium is normal in the upper range of normal. PTH is elevated, significantly elevated, and the state normal vitamin D level and normal 125. The majority of the parameters are normal, so only elevation in parathyroid hormone. The baseline densitometric assessment. Now, these patients frequently they present with low bone mineral density readings, osteopenia, not to the level of osteoporosis. So the T-score is reduced, not terribly so. So a paradox that the group found, the Columbia group and the state, that patients with normocalcemic hyperpara present with more symptoms, so they have more aches and pains and so on than the typical cohort of hypercalcemic subject with high PTH. Maybe, and they attribute that maybe because of referral bias, because it's a bone unit and they get patients with bone complaints. So the common belief now that normocalcemic hyperparathyroidism is a variant of primary hyperpara, and management approach is recommended. And this is their recommendation, just monitoring after assessment for the bone and renal disorder. Calcium and PTH annually, you do DEXA every 1 to 2 years. If they progress to hypercalcemic primary hyperpara, follow the guidelines for hyperparathyroidism. If they need surgery, you refer them to surgery. If progression of the disease to with worsening BMD, so you monitor the bone density and the serum calcium and PTH. Or if they develop kidney stones or nephrocalcinosis, then go for surgery for them, even if the calcium is normal. This is a review that published in 2012, 10 by Belizikian, which I've found it's an excellent one. Diagnosis and evaluation, high calcium. This is going back to primary hyperpara, high calcium elevated or inappropriately normal PTH. I think I'll stop at this stage and just mainly to conclude. Can I take 1 minute more? Thank you, Said. So 2 things that we do in primary hyperpara, renal and skeletal assessment. If there are any abnormalities, you refer the patient for surgery. Fracture risk is elevated in patients with primary hyperparathyroidism. And quantitative CT might pick up abnormalities when the BMD is normal or near normal. So these patients with primary hyperpara, they have abnormalities, subtle abnormalities in the bone, and that's why they are at increased risk of fractures, even with minimally lowered bone densitometry readings. And this is demonstrated in many studies using high-resolution quantitative CT. So the lumbar spine BMD in primary hyperpara is discordant with fracture data, while the high-resolution QCT indices are concordant with fracture data. So in other ways, they are much better in picking up bone abnormalities in patients with primary hyperpara. You need to do renal 24-hour urine calcium assessment. Even the calcium level is near normal, slightly elevated, because the stone risk is high, and if they have renal stones or reduction in GFR, go ahead and refer this patient to surgery. Many of these patients, they have neurocognitive, cardiovascular, or gastrointestinal symptoms. These are non-specific, and the data are not secure enough to decide for surgery based on these parameters. Now, many of patients, there are differences, what people see in the West from what we see in our countries, and this is comparing New York to Beijing. These patients in China, and we belong to that part of the this sort of presentation, where we have a lot of severe vitamin D deficiency, and our patients, like the Beijing patient, they have higher serum calcium compared to what happened in North America, higher alkaline phosphatase, PTH is significantly elevated because of associated vitamin D deficiency, and look at the vitamin D levels comparing the 2 places, where you find patient in Beijing 8.8, and I think in the Gulf we act in the same time. So rule out calcium deficiency, and you follow the national guidelines. Hopefully soon we're going to publish the GCC consensus on vitamin D deficiency. I do thank you for listening, and I'll stop at this stage. Thank you very much.